صباح الخير جميعا. هي دي كانت سيستماتيك ريفيو بنيفالويت الفيمورال ابيرشر بوزيشننج في التو تكنيكس اللي هم الترانستيبيال والتيبيال اندبندنت تكنيك في الاي سي ال سنجل باندل ريكونستراكشن. هي دي كانت الحمد لله ببلشد اونلاين في الجورنال اوف اورثوبيديك سيرجري اند ريسيرش في المارش 2022. انا بحب اشكر زمايلي واساتذتي اللي كانوا معايا في البحث. اولا هو البروبر ابيرشر بوزيشننج الاول كان بنحط الفيمورال ابيرشر فيرتيكال وساجيتال وفيرتيكال بوزيشننج to restore the anteposterior function of the ACL reconstruction. Then we shifted to single bundle anatomical in the center of the footprint. Then we realized that this footprint geometry could be differed from individual to individual, and we shifted to individualized ACL reconstruction. Then we realized that there is two histological appearance of the insertion of the ACL, direct and indirect, and we shifted to put the ACL single bundle in the more functionally bundle, which is the direct fibers. So we have two techniques, transtibial, which is known and it is the old technique, and the tibial independent, and always the tibial tunnel dependent was criticized to place the ideal place. And we could argue that it has some potential or some reasonable freedom to externally rotate the offset guide, because we know that the acorn reamer for the femoral tunnel drilling is smaller than the tibial tunnel diameter, so we could have this reasonable freedom. And also there was modifications suggested to improve this placement. The independent technique could be out-in, could be transportal, and we already know that we have the complete freedom to place the tunnel. However, this does not guarantee the proper placement, as the surgeon might choose improper place. So, this was our aim for the review, to review this aperture placement by both techniques according to the recent concepts of individualized ACL reconstruction and the functional anatomical ACL reconstruction. We searched the electronic databases and the reference lists, and we choose studies which compared the transtibial versus tibial independent, which could be assessed by direct measurement or by post-operative imaging, either plain X-ray, MRI, or CT, and quantified by appropriate method. And our participants were single bundle ACL reconstruction in human or cadaveric studies. Assessed the risk of bias in the included studies by minor scoring system, and provided narrative census, which is arranged according to the measurement method and the imaging technique. And if there were more than two studies measuring the femoral aperture position by the same measurement method on the same imaging modality, we provided a meta-analysis. And when we discovered significant heterogeneity, we explored this qualitatively and quantitatively. This is our flow chart, and we had 55 studies for qualitative census and 35 studies for quantitative census. When we synthesized the surgical technique for the tibial dependent technique, we found from 47 studies mentioned the surgical details that there were 11 studies with modified transtibial technique. These are the studies. We could group this to one of four ideas: either alteration of the position of the tibia in relation to the femur during femoral tunnel drilling, or anteromedial portal assisted transfemoral tunnel drilling technique, or posterior over the top notchplasty, or intentional tibial aperture posterolateral beveling. These are the four ideas which we found for the modified transtibial technique. Then, when we synthesized the tibial independent technique in our included studies, we found that the localization strategy for femoral aperture positioning in the studies varied. Some used the footprint only or with other methods, and some not used the footprint. And these are the studies which we found. These other methods could be offset guide, could be landmarks, could be clock face. Really, we found that there was inability to visualize the footprint in 2/3 of the included studies. And we found also that there was utilization of the general rules of thumb to locate the femoral aperture in all individuals without individualization, without taking into consideration the individual variation. Like to position it at a fixed distance from the boundaries of the intercondylar notch and another methods. So when we synthesize the effects of intervention, this is our core of the review. We could compare it in two approaches, either direct approach to compare the ability of each technique to position the footprint in its position, or indirectly by comparing the quantified foot aperture location placed by each technique. And we localize that, or we define these positions in two planes, either coronal plane or sagittal plane. So, we defined the coronal plane as either to be perpendicular to the Blumenset or to be in the anteposterior axis. Sorry. And we defined the sagittal plane position either to be along the proximal distal axis or along the Blumenset line. So these are our definitions which we will use all through the review. We found two studies that assessed the distance of aperture center to the same knee footprint center on digitized 3D model. When we pulled the results, we found that there was non-significant difference in this distance. And we found two studies that assess the distance of aperture center to the same knee footprint center on assess this in the anteposterior axis. So we have distance which is diagonal from the aperture positioned to the center of the footprint, or could be this distance measured in one of the two axes. Here in the anteposterior axis. We found that there was a significant difference, but with minimal mean difference, which is 3.6 or 3.3 millimeters. Then we found that there were two studies that measured the distance of aperture center to contralateral knee footprint, not the same knee like the previous, on MRI, which was either direct distance or distance in the anteposterior axis. We found that there was non-significant difference in this distance between the two techniques, the tibial dependent or tibial independent, and we found that there was non-significant difference between these two distances in the anteposterior axis. Okay. Then we approached that indirectly, and we found that there were 16 studies that measured or quantified the femoral aperture position by the quadrant method, which was measured on 3D CT. When we pulled the results, we found that there was a significant difference, and the tibial independent technique significantly lowered the femoral aperture in the plane perpendicular to the Blumenset line, and this was difference of 11.3%. Regarding the positioning along the Blumenset line, we found that there was non-significant difference. We could appreciate this in this view, or this figure. This is the 3D CT, and this is the quadrant method, and we are zooming on this black quadrangle. Here, we found these are the 16 dots of the, sorry. خلصت؟ الوقت خلص؟ Okay. We could appreciate that these green dots are lower than these blue dots. And also we measured this, pools that in 4 studies measured it by the anatomic coordinate axis method on the 3D CT. Also, we found that the tibial independent technique put it at more significantly more posterior position. We explored the heterogeneity because we found that there was significant heterogeneity, and we explored this to detect effect modification by the modifications applied to the transtibial technique. When we pool the studies for the conventional, we found that the difference is 15%. When we use or we pool the studies for modified transtibial only, we found it is 1.8. So this modification had significant effect. Okay. So كمان دقيقة ممكن؟ conclusion أهو خلاص. We want to overlap these axes which we assessed on the direct and indirect fibers insertion. We could find that the lateral intercondylar ridge is in 30 degrees angle with the proximal distal axis and in 70 degrees angle with the Blumenstadt line. So when we overlap this, we could appreciate that, or we could suggest that the more anterior and the distal placement of along the anteroposterior and the proximal distal anatomical axis would be more advantageous, not the reverse, and the differential in the aperture placement along the perpendicular to Blumenstadt line may not be so crucial if the aperture placed closely behind the intercondylar ridge. So to conclude, we found that both techniques were unable to accurately recreate the anatomic footprint position, and while the difference between both techniques was non-significant في aperture placement in the sagittal position, it was significant in the coronal plane positioning. And this significant difference in the coronal plane positioning could be either perpendicular to Blumenstadt line, and we found that this difference, which is along the perpendicular to Blumenstadt line, could be not so crucial and could be overcome by the modifications for the transtibial technique. Regarding the positioning along the anteroposterior axis, we found that the more posterior positioning of the tibial independent technique could not be advantageous according to the recent concept of direct and indirect insertion and functional ACL reconstruction. Thank you for listening, and sorry for listening because it is really extensive review. Thank you.
Thank you, Dr. Haitham Haroun. The next speaker